Good morning, children. Today, we will quickly recapitulate what we discussed in the last class and we will continue the adrenal cortex, especially the zona glomerulosa, and we see in detail. So, we have seen the suprarenal gland, which is the adrenals, which is about 4 to 5 grams in weight. It's a capsulated organ located intrapectorally, having two distinct regions as cortex and medulla. Cortex secretes the glucocorticoids, neurocorticoids, as well as adrenal androgens. The medulla secretes the catecholamines. So we have seen the various distinctions. This is the connective covering. This is the cortex having zona glomerulosa, superior layer, outer layer, and middle layer is about 3/5 of the cell mass is zona fasciculata, which secretes glucocorticoids, and zona reticularis, which secretes primarily the adrenal androgens. So, the cortex, stimulated by the ACTS secretes corticosteroids, we have seen in detail, and these are the three corticoids, mainly melanocorticoid, glucocorticoids, and gonadotrophic are adrenal androgens. And melanocorticoid is the aldosterone, and where it acts, the target organ is the kidneys. What are the primary acts? It affects the sodium and potassium balance, and how it brings about this action. Of course, the aldosterone is having a receptor in the cytosol. When it binds to the aldosterone specific receptors, of course, to the same receptors, even the glucocorticoid also can bind. That's why it is called as type 1 glucocorticoid receptor. When aldosterone binds to the type 1 glucocorticoid receptors, this receptor hormone complex moves internally through nuclear pore to the cell, where it stimulates the transcription of certain gene sequences, thereby it stimulates mRNA synthesis. And the mRNA which code for the channel protein, that is sodium, potassium, ATPase. So it brings about the protein synthesis. Rather, it stimulates mRNA synthesis, which codes for sodium, potassium, ATPases. So the sodium, potassium, ATPase, you know its function. Of course, little more detail we'll see quickly. So they are located at the basolateral membrane of the renal tubules, where they move the sodium against the concentration gradient into the interstitium. From interstitium, it is again moved into the blood. So they try to keep the intracellular level of sodium at check, which facilitates the reabsorption of sodium from the filtrate into the at the luminal surfaces. So thereby it helps in the reabsorption of sodium, and there will be more aldosterone, which leads to more sodium reabsorption. More sodium means sodium is otherwise called natrium, water-loving electrolyte. So it will have affinity for water, so it also along with sodium, water also will be retained. So whenever more aldosterone is there, means there is a sodium and water retention will be there. It will go side by side. So whenever there is a stress, and which leads to the release of the releasing hormone, corticotrophin releasing hormone from the hypothalamus, and which causes the release of ACTH, adrenocortical hormones, from the anterior pituitary, which causes the release of aldosterone from the zona glomerulosa, and which leads to sodium and water retention, and which leads to increase in ECF volume and leads to the blood pressure. In the sequence. So glucocorticoid, of course, we have seen in detail, and today we'll discuss our This is the synthesis. Also, we have already completed. And we are going to see only the aldosterone. The precursor molecule is the again cholesterol. The cholesterol from where its pregnenolone is synthesized. From pregnenolone, it is the progesterone is synthesized, and by the action of the 2022 desmolase from progesterone, again the corticosterone as well as 18 hydroxy corticosterone as well as aldosterone are synthesized sequentially. So even 18 hydroxy corticosterone also having very less mild corticosteroid activity, but the major component is the aldosterone, which is having the profound mineralocorticoid actions. So up to this is again a common pathway from where the different precursors or intermediaries from where other hormone substances can be synthesized. These things are the rate limiting steps. Once pregnenolone, the progesterone is synthesized, from where other hormones are synthesized by various enzymes. So here between corticosterone to aldosterone, where the enzyme involved is the aldosterone synthase, which is a mitochondrial enzyme having affinity for the cytochrome P450 oxygenase enzyme, which is involved aldosterone synthase that helps in the conversion of corticosterone into aldosterone. This is the synthesis. Of course, the detail you might have learned the detail in biochemistry, but from cholesterol, pregnenolone, this is synthesized by various desmolases and hydrolases. These are all the actions of the glucocorticoids we have seen. And we will restrict our discussion to the mineralocorticoid today. So all we have seen in the last class, Cushing syndrome, hypercortisolism, and it's a clinical disorder, and the features also. We discussed in detail. Today we will go back quickly. We will recapitulate about again we have seen about the enzymes involved, the 21 hydroxylase, 11 beta hydroxylase, 18 hydroxylase, it is 18 oxidase. These are the enzymes involved in the synthesis of aldosterone. So this particular enzyme can be inhibited by, it is promoted by amino thymide, and it is prevented by matrapore. These are the synthetic drugs which are used in treatments. Of course, these are some of the drugs which are used, we'll see, to the aldosterone. It is a mineralocorticoid synthesized from the cholesterol molecule, and it is produced in the zona glomerulosa, because that is the area where in these areas in the mitochondria the aldosterone synthase enzyme is there. So that oxygenase enzyme helps in the formation of aldosterone from corticosterone, and it acts on the kidney via receptors. As I said, the same receptor is to which even the glucocorticoid also will bind. That's why it is called as type 1 glucocorticoid receptor. And what are the actions? Number one, it helps in the sodium and water reabsorption. Sodium and water reabsorption, especially at the late distal convoluted tubule as well as at the collecting duct. Late distal convoluted tubule as well as collecting duct. These are the areas where, more specifically, there will find two species of cells. One is the intercalated cells next to the principal cells. Of course, they act on the principal cells. They act on the principal cells where they mediate their actions. What they do, where they cause sodium reabsorption and potassium secretion, as well as the sodium reabsorption also coupled with hydrogen ion secretion, H plus ion secretion. So they bring about sodium reabsorption and they cause both potassium and hydrogen ion secretion. Of course, it also coupled with ammonium excretion. To a certain extent, it also causes the magnesium ion excretion. Of course, these two, ammonium and magnesium, to a limited level. Of course, the potassium and hydrogen secretion is profound, which is coupled with sodium reabsorption. And ammonium and magnesium are secreted only to a lesser extent. And even infusion of small dose of aldosterone will cause increase in BP due to the above mentioned reasons, because of the sodium and water retention, which leads to increased ECF volume and increased blood pressure. In addition to the renal tubules, it also causes sodium absorption, especially in the colon, and which prevents the loss of sodium in the stools. Of course, they have action in the sweat glands as well as where they bring about the primary secretion of sweat, and it causes the absorption of sodium reabsorption, so that they promote the sodium retention in the body. This is another function. So, which modify the primary secretions of sweat glands. Now, the control of aldosterone release, or how aldosterone is being released, what are the various factors or stimulants which can modify, which can cause the release of aldosterone. Of all, the first and foremost is the RAS system. What is the RAS system? Renin, angiotensin, aldosterone system. So when or how this particular system is stimulated, whenever there is a fall in BP, when the blood pressure is low, the pressure in the renal artery supplying the kidney will also be low. So in the afferent arteriole, the hydrostatic pressure will be low. So that means when hydrostatic pressure is low, the GFR will be low. The filtration rate, net filtration pressure will decrease. Due to decrease in net filtration pressure, due to decrease in GFR, less amount of filtrate will be formed, and that will be flowing through the different segments of nephron, especially when it is processed through the proximal connector tubule. When it reaches the distal tubule, at the beginning of the distal tubule, where you will find the macula densa cells. Due to decreased hydrostatic pressure, due to decreased net filtration pressure, the amount of filtrate will be less. So the velocity of flow, or the flow rate within the nephron will be slow. So most of the available sodium will be effectively reabsorbed. So by the time the filtrate reaches the macula densa, the sodium chloride content will be low. On the other hand, if the pressure is more, the GFR will be more, the net pressure will be more, so more filtrate will be formed. So the reabsorption of sodium will be less. So by the time the filter reaches macula densa, the sodium chloride content will be normally high. So in this case, whenever there is a fall in BP, fall in the renal hypoperfusion, which leads to renal hypoperfusion. Suppose we call it as the decrease in hydrostatic pressure, decrease in net filtration pressure. So GFR will be less, the flow rate will be slow. So actively and passively, most of the sodium will be reabsorbed. So by the time it reaches macula densa, the cells which are chemosensitive cells, they sense low sodium chloride content, or low sodium content. So in response to that, they cause release of certain chemical mediators, and which in turn causes the release of renin from the neighboring structure in the juxtaglomerular, that is the juxtaglomerular cells. They release renin. This renin will convert angiotensinogen into angiotensin 1. Renin is a mediator, or you can say local hormone, released from juxtaglomerular cells in response to low sodium chloride content at macula densa, which converts angiotensinogen into angiotensin 1. This angiotensin 1 is further converted to angiotensin 2 by angiotensin converting enzyme or ACE. This angiotensin 2, of course, it will be further converted to angiotensin 3 also. Of course, the more important intermediary in this cycle is the angiotensin 2. The angiotensin 2 is having multiple roles. The profound role of this is which will act on the glomerular cells. So they have this glomerular cell have specific receptors for angiotensin. When this angiotensin bind to this, which leads to the synthesis of aldosterone and release of aldosterone from these cells, from cells of zona glomerulosa of adrenal cortex. In addition to this, by stimulating action of angiotensin on juxtaglomerular glomerulosa cells, it has got direct effect. It is a powerful vasoconstrictor which causes a vasoconstriction. Thereby, it will increase the peripheral resistance, so that try to increase the blood pressure. Number one. Number two, it also acts on the osmoreceptors, as well as it also acts on the thirst center, thereby which will cause the feeling of thirst, thereby the person will drink water. By all means, it will try to add the water into the system by drinking, as well as it also causes vasoconstriction, thereby to try to increase the blood pressure. Third, which causes release of aldosterone. This aldosterone will cause sodium and water retention. Thereby, by all these means, it will try to correct the fall in BP, so the BP will be brought back to normal. So this is one of the inherent mechanisms, that is called auto-regulator mechanism found within the kidney. Whenever the blood flow to the kidney becomes less, it will try to compensate by these mechanisms. It will try to bring the blood pressure back to normal. Whenever there is a renal hypoperfusion, it will be corrected automatically by kidney's own mechanism of contrast, that is the renin angiotensin aldosterone system. That's why it's called as auto-regulation. Within a particular pressure range, even though there is a change in systemic arterial blood pressure, the blood flow, because kidney is an organ which is very much essential, it has to work where the blood flow has to be ensured correctly, so that all the waste products, nitrogen waste, has to be eliminated as and when they are being produced. Otherwise, it will be detrimental to the health of the individual. That's why it will try to ensure a normal blood supply, normal perfusion by auto-regulating the blood pressure and blood flow to the kidney. So that's why the renal auto-regulating mechanism, that is the renin angiotensin aldosterone system. So now this is how the angiotensin 2, by binding the specific receptors on the cells of zona glomerulosa, causes release. This is one of the primary stimulant by which the aldosterone is released. So it acts on adrenal cortex, that causes. The second important stimulant by which the aldosterone releases the plasma as potassium level. Whenever there is an increase in the potassium level, even by 0.5 milliequivalents per liter, such a small variation also causes the aldosterone release by threefold. So suppose we may take a diet containing from as low as 50 to 200 milliequivalents, but the dietary intake may vary in a day. So whenever we take low potassium containing diet, suppose for example 50 milliequivalent per day, then there will be a basal secretion. By the time, suppose we take diet which is having high potassium content, say about 200 milliequivalents per day, then the release of aldosterone from the cortex will be increased by 6-fold. You can say even the slightest change in potassium level will cause profoundly causes the release of aldosterone. One is the renin angiotensin mechanism, whereby the release of angiotensin 2 by this system will cause the release of aldosterone. Second mechanism by which it is stimulated to release is the level of potassium. A small slight change in potassium level, especially hyperkalemia, can lead to increase in the aldosterone level. Next is the STH. So of course, unlike the other hormones, especially the glucocorticoid as well as the adrenal androgens, where primarily the STH plays a role. Whenever they stimulate action by STH on the specific receptors in the zona reticularis as well as on the zona fasciculata, they cause release of the glucocorticoids and sex steroids. But whereas here STH plays a very minimal role, very minimal role. It's primarily governed by angiotensin mechanism as well as by the level of potassium. STH has got, of course, it has a role, but a very limited role, a very minimal role. So you can say the cells are less sensitive to release ACTH. Of course, they are more sensitive to angiotensin 2 as well as the level of potassium. Of course, angiotensin 2, as I said, is having specific the adrenal cortical, especially zona glomerulosa. Those cells, they have specific receptors. The binding leads to the release. Now, how the potassium ion brings about this action? Of course, the potassium ions will cause us the depolarization of the zona glomerulosa cells. The membrane gets depolarized due to increased potassium levels. Once the membrane gets depolarized, now this depolarized membrane will cause, which leads to opening up of voltage-gated calcium channels. Voltage-gated calcium channels, there will be an influx of calcium inside. So once calcium ions enter inside, the calcium level will increase. Now it will bind to another calcium-binding protein called calmodulin. Now this this calcium calmodulin is a complex which will activate certain protein kinases. So this protein kinases in turn will lead to the release of hormone, that is the aldosterone. Even the increased calcium itself will cause the release. So this is the mechanism which primarily potassium brings about the release of aldosterone by causing membrane depolarization. This membrane depolarization leads to opening of voltage-gated calcium channels, and this entry of calcium and increased calcium level within the cell brings about the release of adrenal aldosterone hormone. That is the stimulant by which it is being stimulated. So this once it is released, this aldosterone will as it causes the absorption of sodium and water and causes secretion of potassium. Potassium level will decrease. Thereby, it will try to bring about a change which are in opposite of the beginning. How the mechanism which stimulates the angiotensin release will be inhibited by all these axes. By once sodium and water is retained, by thirst mechanism, water is taken inside. So the blood volume will be normal, or ECF volume will be normal. ECF volume will try to increase. So by sodium and water retention as well as by thirst mechanism. So the initiating stimulus will be no more there, or they will work. The correction will be made in direction opposite of the initiating change. Initiating change is the renal hypoperfusion. The renal hypoperfusion will be corrected by increase in ECV, extracellular volume. So ECF volume will increase. So which corrects the initial change. Renal hypoperfusion will be corrected by this mechanism. So aldosterone syndromes, suppose whenever there is a increased production of aldosterone, it produces a syndrome called Conn's syndrome. And whenever there is a lack or deficiency of this aldosterone, produces Addison's disease or Addison syndrome. And sometimes it also can lead to congenital adrenal hyperplasia. So those things we will see a bit later. So as I said, the main neurocorticoid is the aldosterone as well as deoxycorticosterone, and to a slighter extent it is 18-hydroxy deoxycorticosterone. They are all released from the zona glomerulosa, and as I said, they bring about the action by binding to the cytosolic type 1 glucocorticoid receptors, and this hormone receptor complex moves inside where they brings about protein synthesis by producing more mRNA, which are especially RNAs, which will code for the sodium potassium pump. And how it brings about this all these actions? Number one, it increases the permeability of membrane for sodium. It increases the permeability of membrane for sodium by increasing the sensitivity. Now it has got two things. A luminal membrane, the membrane is those cells, epithelial cells, transient epithelial cells lining the renal tubules. They have two surfaces. One is the luminal surface, other the basolateral surface. In basolateral surface, you will find the sodium potassium pump, and on the luminal membrane, where the sodium ions are absorbed. So this area of the membrane, those it will cause the expression or production of more number of aldosterone dependent protein or induced protein, aldosterone induced protein. Suppose the protein which is produced due to the action of aldosterone. Aldosterone, as I said, binding to receptor, bring about gene expression. It produces certain protein. They are called aldosterone-induced protein. This protein will cause, or which cause the sensitivity of this luminal membrane for sodium reabsorption. So it brings about a change or increase in the sodium reabsorption in the luminal membrane. Number one. Number two, there is another species of channels through which sodium is reabsorbed, that is the thiazide sensitive sodium chloride channels. Thiazide sensitive sodium chloride channels. It will try to increase the number of thiazide sensitive sodium chloride channels. So thereby it will try to increase the sodium reabsorption. Of course, as I said, above all, it increases the number of sodium potassium ATPase in the basolateral membrane. It brings about increased reabsorption in the luminal membrane by activating the aldosterone-induced protein, which increases the sensitivity of the membrane for sodium reabsorption. Of course, it also increases the number of thiazide-sensitive sodium chloride channels in the luminal membrane. On the basolateral side, it increases the number of sodium potassium ATPases, which in turn will transfer the sodium from the cells into the interstitium, later into the bloodstream. So, where actively sodium will be pumped out. So, it creates low sodium content within the membranes, and so the luminal membrane side, there will be increased reabsorption. Of course, in addition to this mechanism, which are the channel proteins which are acting on luminal and basolateral membrane, it also causes the expression or stimulation of certain enzymes involved in Krebs cycle. You know, Krebs cycle is an important cycle. It is used for the production of ATP, which will that is the cell's energy fuel. So it causes the production of more ATP. These ATPs are in turn used for the activity of sodium potassium ATPase. So as I said, even under basal metabolic rate, under basal conditions, in our body, whatever food we consume, so of which 50% is used as for the even for maintenance of sodium potassium pump alone, to maintain the ionic balances between inside and outside, to maintain this for the activity of sodium potassium pump, which consume 50% of energy. Here also, as I said, there is a more and more number of sodium potassium pump. Those proteins are being inserted into the basolateral membrane, and when they carry on their biological activity or physiological activity, that is the pumping of sodium outside, for which energy is needed to produce this energy, to supply this energy, the aldosterone stimulates enzymes involved in Krebs cycle. So not only increase the channel, of course, it energizes those channels by producing more ATP by inducing Krebs cycle or TCA cycle. And it also increases the phospholipase activity. Phospholipase enzyme activities increase, so which leads to the production of more number of free fatty acids. These free fatty acids in turn will help in the generation of biomembranes, within the cell. So which increase the overall membrane generation. Membrane generation is increased, membrane surface area is increased by producing more free fatty acids, as well as it also causes the expression of more channel protein, which are acting both on luminal membrane as well as basolateral membrane, as well as it also stimulates enzyme responsible for production of more ATP. Well, all this means it try to help or try to do more sodium reabsorption. That is the mechanism of action and modality by which it brings about the action. So now, whenever the aldosterone level becomes more, as that primary aldosteronism, that otherwise called as Gaunt syndrome, it is a condition in which there is a prolonged excessive secretion of aldosterone from an adrenocortical adenoma. It's a cancerous disease. So, where due to this malignant condition, where the cells under hyperplasia, and they bring about the increased level of aldosteronism, hyperaldosteronism. So, what are the features we will see? As I know, when aldosterone level becomes more, there will be hypernatremia, increased sodium and water retention. On the other hand, there will be hypokalemia because it stimulates or it favors potassium ion secretion. So potassium ions will be secreted, so there will be hypokalemia, and there will be hypervolemia. Sodium and water will be retained, so hypervolemia will be there, and which leads to hypertension. And there will be, so due to hypertension, the blood pressure will be more, there will be polyuria and polydipsia. There will be increased excess urine formation due to the increase in volume, the pressure, diuresis will be there. Due to increase in volume and pressure itself, there will be polyuria. As said, to compensate that, you know that there is an increased aldosterone level which causes polydipsia. So to compensate the volume, there will be polydipsia, and there will be absence of edema, and there will be alkalosis, as well as due to hypokalemia, there will be muscle weakness. The excitability of membrane will not be maintained properly. There will be muscular weakness will be there. There will be alkalosis, because alkalosis due to the excess release of H plus ion secretion. Excess secretion of H plus ions, because some of the sodium is absorbed along with secretion of potassium. Some sodium is reabsorbed along with H plus ion secretion, so which leads to metabolic alkalosis. So these are the features. In secondary aldosteronism, so where there is an increased level of aldosterone hormone, but the primary cause is not due to the adrenal cortex alone, which is due to cause elsewhere, due to other factors, extra-adrenal factors, which brings about secondary aldosteronism. So again, here also the features remain the same, except here there will be edema. The patient will be edematous, but the cause is not the adenoma of the adrenal cortex. The cause is different, but the features will be remain same. Of course, it can be treated by using certain diuretics like spironolactones. They are called the potassium sparing diuretics, spironolactones, as well as amyloride diuretics, or it can be treated by ACE inhibitors. ACE inhibitors is an enzyme, you know, angiotensin converting enzyme. Whenever we use ACE inhibitor like naloxone, captopril, lisinopril, etc., when these pills, when they're used, they inhibit the formation of angiotensin 2. When the less angiotensin 2 means there's no activation of angiotensin 2 on glomerular cells, as well as its action on the third center will be withdrawn. So the secondary aldosterone will be treated by using ACE inhibitors also, as well as by giving certain potassium sparing diuretics such as spironolactones, as well as amyloride diuretics. So now, in addition to the melanocorticoid and glucocorticoid, they also secrete certain androgens, especially dihydroxy androgens, that the DHEA, that's a major androgenetic androgens, which also synthesized from the cholesterol via pregnenolone, and which leads to from this little known by successive conversion, it can produce various adrenal antigens, as the DHEA as well as androstenedione. This androstenedione can lead to further enzyme catalyzed reactions, can produce both the estrogen, progesterone, as well as testosterone. Of course, in a very little quantity compared to the other primary secretors, like especially for testosterone, we have testes, as well as ovary, which secretes primarily estrogen and progesterone. They also can secrete, of course, to a lesser extent. Especially when you look at the development of the adrenal gland, especially adrenal cortex, during the fetal life or embryonic life, it is larger in size. They contribute for the secretion of these androgens, which are used for the fetal development of these characters, etc. Of course, in adult life, the level is or their role is very limited because we have ovaries and testes. They secrete more of these sex steroids. So they have primary function. Of course, they can also contribute to the development of secondary sexual character in both male, especially in female. There are certain there's a role of male hormones, which primarily comes from the androstenedione, and the level of estrogen, etc., produced from these adrenal, the cortex, especially the zona reticularis, is very, very limited till menopause. Of course, after the menopause period is sets in, then there is a considerable amount of the estrogen. Now it comes from the adrenal cortex rather than from the ovaries for a certain time. So now, whenever the adrenal cortex undergoes certain cancerous growth, now in this case, which can secrete more of these androgens, which can bring about certain undesired effects like it becomes virilism, especially in females. So that's what we are going to see now. Adrenocortical tumors secrete excessive quantity of androgens that cause intense muscularizing effects throughout the body. Suppose even the female will have male-like muscle body, and the development of the axillary and pubic hair and hair over the chest, etc. And even the breaking of voice, etc. Like male, it can happen in a female. And occasionally, adrenal tumors secretes estrogens to produce feminization in males. Of course, now the development, enlargement of breast and atrophy of testis, and there will be diminished sexual interest towards women. These things can happen. So it can develop virilism in female, and of course it can have atrophy of testis as well as enlargement of male breast, gynecomastia, etc. Decreased libido, etc. can happen in males. So these are the changes you can see. Body hair, increase body hair growth in female virilism. Now, whenever there is an adrenal cortex insufficiency, this corticoid hormone becomes less, then it leads to a condition called Addison's disease. So there is an inability to destruct from adrenal cortex, and or it can be due to diminished secretion of ACTH due to adenohypophyseal hypothalamic failure, or because the CRH, corticotropin releasing hormone, comes from the hypothalamus in that axis, or maybe there is a pathology of the anterior pituitary from the ACH, which is coming, which may be low. Both can lead to adrenal. Primarily, it can be due to disease of the adrenal cortex, or maybe at the hypophyseal axis, or at the anterior pituitary level. Or it may be genetic, it may be due to congenital failure of cortisol secretion, and due to certain defects in the enzymes involved in the synthesis. So, by any means, maybe destruction of adrenal cortex is due to hypothalamus, or maybe anterior pituitary, or certain genetic defect where the enzyme involved in the synthesis may be affected. By all means, that will hormone, especially aldosterone, may be totally absent or it may be insufficient, which can lead to Addison's disease. In Addison's disease, there is a chronic deficiency of both melanocorticoid as well as glucocorticoids due to destruction of adrenal cortex. So these are the Addison's disease, where the patient of Addison's disease. So you can see the features. The muscle will become weak, weakness in the musculature, and there will be hypoglycemia. There will be hypovolemia as well as hypotension, and there will be anemia because the glucocorticoids help in the formation of RBC, etc. They help in the glucose homeostasis also by interfering with you can say anti-insulin effects, etc. Those things are now lost. As I said, the glucocorticoids have played a role in the carbohydrate metabolism, protein metabolism, lipid metabolism, etc. So that metabolism now, due to that effect, there will be hypoglycemia, and the sodium and water is lost, leads to hypovolemia, leading to hypertension. As the erythropoietic effect will be lost, so the patient will suffer from anemia. And so normally glucocorticoids prepare the individual to face the stress, the anti-stress hormone. Now that effect is removed, so they will be more vulnerable. The resistance to stress and infection will be less, and there will be disturbed electrolyte balance. There will be electrolyte imbalance because of the activity of aldosterone is being not there, or its level is too low to maintain the normal sodium and potassium levels. So there will be electrolyte imbalance. The patients suffer from anorexia, loss of appetite, nausea, and vomiting, and there will definitely weight loss because of its effect on the metabolism as well as on the sodium and water retention. So the patient will suffer from weight loss also. So sometimes the patient also develop vitiligo and the change in the pigmentation of the skin. Now it can be treated by replacement therapy by giving glucocorticoids and glucocorticoids as well as certain steroids. They are the synthetic derivatives of glucocorticoids, especially dexamethasone, betamethasone, prednisolone, etc. When these things are given, normally the condition will be reversed. So with this, we'll complete the discussion on adrenal cortex and the hormones. So try to go through. Now there is a discussion we had today regarding the reopening of college. We are going to develop SOP, the standard operating procedures, with 1/3 of students coming and staying for 10 days. Those things, more details are being worked out. Things will come soon. So wait for the information from the authorities. So we are awaiting the dates from the university. Anytime after Deepavali, the classes will resume, maybe in a staggered way. Not all students may be caught at once. So things are being worked out. Be prepared, and we will try to complete all your theories. And when you come here, there will be more training on practical aspects, and the completion of record book and log book will be there. So be mentally and physically prepared for those things. So with this, we'll complete today's thing, and we'll see some in the later part of this week with another topic. Thank you.